Good afternoon, everybody. It's my distinct pleasure to introduce Katz for his talk on 40 years of orthopedics at Yale. I see a lot of young faces out here. I don't know how well you know Dr. Katz, but Dr. Katz is, he's an enigma. He has many faces. He has his hands in many things that I'm going to try to show a few pictures of today. So, okay, so this is the Lee Katz everybody knows, the bone radiologist, the properly dressed person. But how many of you know what the young Dr. Katz looks like? Well, there he is. A lot more hair, a lot better looking. I think that's, what's your ID badge from University of Illinois or something? Okay, well, Katz is also known for doing some strange things with our fellows over the years, some of which have been documented at the end of the year dinner. As you see on the left, this is him with Dr. Vittori doing some strange pose I'm not sure about. And then one of our fellows couldn't make grand rounds, so he made a cutout of him, or no, at the end of the year dinner, so he made a cutout of him, so he was there not only in spirit, but in cardboard. Okay, and you know, Katz can be a jokester and joke around a lot. Well, here's a picture of Katz as a clown with a clown nose on. I'm sure you all know about him as the Republic of Tea Man, and I just got a picture of him winning a tea award. There he is with a teapot. I think he dropped on my head one year. I'm sure nobody has seen Katz as a cowboy before, but you know, he's got some in-laws up north, and he can play the role of a cowboy too. There he is, as a cowboy. Katz the Fisherman. You know, he's been known to do some fishing, and there he is with a very large fish, screaming for help.
Come on, talk to me, Jack. Talk to me.
Okay, and sorry. And last, we have Katz the Fishmonger. I'm not sure if you guys are aware of this, but Dr. Katz works at the Starfish Market on Saturday mornings, slicing locks. Very good at it.
So when I give my talk in April, you can show it, right? As my introduction.
Introduction. Show Katz.
Some locks. He's like a
slice.
Okay.
Run for his money in the operator.
Oh my God! Look at that.
But I will tell you, if you're ever in the bone room, he has his set of Katz rules, and if you remember one rule as a resident or a fellow or another attending, if you remember one rule, you'll get by very well in the bone reading room, and that's Katz makes the world go round. So as long as you remember that, you'll be okay. So with no further ado, it's my distinct pleasure to introduce Dr. Katz.
Well, thanks, Andy. That was unexpected, to say the least. I think that most of you in the room know that June 30th is actually my last official day here at Yale. So that the reality is that I have some mixed emotion today about giving this talk, but I'm very happy to be here and honored to have been asked to give grand rounds. So today I'm going to talk a little bit about my experience here at Yale, 40 years of both radiology and orthopedics. And my objectives are sort of to document my personal travel through both of the departments. I'd like to highlight some important historical events and images. And probably most important, I'd like to make everyone in the audience, and I guess in our world of people online, to be aware that there have been some many important accomplishments that have been done here at Yale Radiology. And throughout the talk, I'd like to recognize a small group of individuals and the lessons that they taught me. So in terms of disclosures, I have no financial relationship with any radiologic or orthopedic companies. But as Andy alluded to, I'd like to recommend that the next time you want to relax, you may want to try a nice cup of tea from the Republic of Tea. It's a great tea company. And in fact, if tea is not your thing, a glass of Pinot Noir or Chardonnay from the Russian River Valley may be just the thing. River Road's a great brand. It's also available at Total Wine and More in Milford. So 1976 is when things began. And Andy stole one of my pictures, but this is me leaving Chicago in 1976. It's actually a picture from a U-Rail pass that I went on a European vacation before I came to New Haven. It's interesting to look back at 1976 for, you know, most of you probably weren't born, but gas was around 59 cents a gallon. The average income was around $16,000. Apple Computer was founded by Steve Jobs and Steve Wozniak. The first space shuttle Enterprise was unveiled. And for the music lovers, Diana Ross, Paul Simon, Elton John, Rod Stewart, and Queen actually made their initial presentation. So I came to New Haven in 1976, and my first chairman was Sam Thier. And Sam was an incredible young man and a charismatic figure. He came from the University of Pennsylvania as a product of Dr. Arnold Relman. And Dr. Relman at that time was chairman of, editor of the New England Journal of Medicine. And Sam taught many things, but one of the lessons that was really important to me was the concept of commitment. Sam taught about commitment, and he said that once you shake your hand with someone on any kind of a deal or a job, that was your commitment, and that in fact the next day if something better came along, you needed to honor your commitment. All right, so I began my residency in internal medicine in 1976, and in 1978, I was the senior consulting resident in internal medicine, and I was asked to see a patient on Tompkins 1. Tompkins 1 was the orthopedic floor here at Yale New Haven Hospital. So my first patient was EW. So EW was a 56-year-old female who had a history of a trimalleolar fracture. She had a fever of 103. She was tachypnic. She had a chest x-ray that showed a right lower lobe pneumonia, which was probably consistent with aspiration. She was diabetic, which was out of control. And so it was very clear that she needed to be transferred to internal medicine. So in those days, I'm not sure if it still happens, you usually call the attending, talk to the attending, and you know, within a matter of minutes, they usually said it sounds appropriate. So I called the attending, he was out of town, and I ended up getting in touch with Dennis Miller, who was at that time on the faculty here, a liver attending, and I discussed the patient with him, and he agreed within minutes that the patient should be transferred. So he then said to me in a very polite way, did I have any further questions? And I said, well, I had one. And he said, well, what was that? I said, well, you have a very attractive woman working in your department, in your lab, and I was wondering if you would mind giving me her name. And he said, Laura Jean. He was from South Africa. And I said, Laura who? And he said, well, he said he thought that was an interesting kind of a matchup. So he fixed us up. And 16 months later, I married her. And that's a picture of my wife, Laura Jean. And because of that, I have two great young men that are my sons. I have two fantastic daughter-in-laws. And I have two great grandchildren. So I want to thank Orthopedics and patient EW for my encounter. That was my first orthopedic encounter. So I finished my internal medicine residency, and then Dr. Thier convinced me that I was good with numbers and that I should be a nephrologist. So I went ahead and did a clinical year of nephrology. I was in the laboratory. I went to the NIH. I helped establish the isolated perfused kidney model, brought it back to Yale, and then was on the faculty, and then was asked to go to the dialysis unit to see a patient who had an orthopedic procedure, an above-the-knee amputation. So I looked around the dialysis unit, and I think most know the stories. I quickly realized that there were more patients than legs, and I decided that maybe nephrology was not exactly the place I needed to be. So at that time, I was working with an interventional radiologist, Dr. Glickman. I was doing glucose transport across the liver in diabetic patients. And he said, you know, Katz, radiology is where you belong. So guess what? From 1983 to 1986, I went back and I did another residency in radiology. And I did it under the direction of Dr. Greenspan. Now, I would assume that most of you in the room have never even seen a picture of Dr. Greenspan, but we sit there and go to his conference room every day. He was, you know, an incredible man. You know, one of the people in American radiology, especially chest radiology. And he was there with his, you know, ever-present pipe smoking. And, you know, he was sort of ornery, especially if he had a couple of martinis the night before. But, you know, people that smoked pipes in those days, that really wasn't considered smoking. They never thought that was really smoking. And it wasn't really smoking until he always lit his pipe just below the fire alarm, which would then go off and run. And, you know, he would pull me away and we would kind of laugh. But Dick Greenspan actually taught me another important lesson, and that lesson was family. And it wasn't only the radiology family that we work with every day, but it's also the family that we go home to every night. And Dick had an incredible tact for knowing everybody's names and children and wives and grandchildren. And every year he would have a party at his house with clowns and a hot dog guy, you know, giving hot dogs to the kids. So, you know, Dick, there was another side to Dick Greenspan that a lot of people didn't know about. So this is 1986. This is studying for our boards in the Hewitt Library. This is my group. You can see I cleaned my act up a little bit, cut my hair, wearing a tie, and we all passed our exams. 1986, just to give you a little bit of update, gas was up to 89 cents a gallon. The median price for a house was around $80,000. A Ford Mustang was around $7,000. Top Gun, Crocodile Dundee was coming out on to the theater. And again, just to think about it, Billy Joel, The Police, and Bruce Springsteen made their debuts in 1986. So I came onto the faculty and everybody thought that I was going to be a GU radiologist because of my background and, you know, in kidney disease and internal medicine. But Dr. Greenspan had a different idea and he said to me, Katz, you're going to be a bone doctor, you know? And I said, okay, that's, you know, you didn't argue with him. So the next thing I found, I was working with Dr. Lawson, who was my mentor, and he was happy to see me. He took me around. I met a lot of people through Jack Lawson. But it's interesting to know that Jack actually became famous also because of an orthopedic surgeon. There was a foot surgeon in New Haven who presented Jack with some interesting studies of about 10 patients who had foot pain and had normal foot x-rays, but had normal abnormal bone scans. And it was shown that the accessory bones had either been injured or fractured. And Jack then wrote this paper up, which became, in our world, known as painful normal variants. And Jack actually ended up traveling around the world speaking about painful normal variants, not only in the foot, but in every other place in the body. 1987, I think I made my first maneuver. I waited a year before I started speaking out and decided to try to bring 3D imaging to Yale. At that time, 3D reconstruction was essentially kind of a gimmick that was on CT scanners. The imaging wasn't really great. You know, it was some sort of a software program that they put on. It was sort of like a bell and a whistle, and the imaging was okay. Bone stuff was pretty good. But I happened to find a independent company, one of the kind of burgeoning companies in Toronto called ISG. They were the first person to come up with an independent workstation. And at that time, I coerced Kathy Camputaro, who sort of was a maven of all things. She had done CT, she had done MR, and I kind of convinced her to try to see if she would help me get this 3D program going. And I'm glad Kathy's here today. I must say she's the only person in the room who may be here, except for maybe Burrell, I'm not sure, who has been here longer than myself. Kathy just celebrated her 50th year at Yale New Haven Hospital. So my condolences and congratulations. So the value of a 3D workstation, which we got moving, was we were able to produce multiple objects that could be manipulated independently, which was something that wasn't available on the traditional software scan. We could obtain some valuable information, including volumes. We could calculate angles. And most important, we could help the surgeon, especially the orthopedic surgeon, in preoperative planning. We introduced the concept of segmentation and understood the difference in building a 3D model with CT or MRI. So for CT, bone was pretty easy because it depended on the house field units, which were 2,000 or greater, and you could easily identify the bone. But you'd find out how much more difficult it was with MR, since the variation was really quite small, averaging around 75 house field units. So one movement in the other really can give you a very different kind of appearance, and it was really more of an artist's rendition. So this is just an example from one of the old studies. You can see we took a CT to pelvis. The computer could identify the outline of the bones, and each one of these bones could be a separate object. And then with the segmentation, we could actually sort of like paint, pour into this area, and then we could build a model. And we could do a lot of different things with the model. We could bring the pieces in, take the pieces out, but the surgeon then could become very interactive with the injury and then come up with a game plan. So the 3D imaging so this is now 1987, right? And it really replaced the whole concept of tomography, which we don't even have those machines anymore, thank goodness. There was obviously no extra radiation involved. As I was saying before, the physician could become interactive with the model. And the whole concept is that we could improve patient care. The surgeons would actually sit down, move us away from the model, and come up with their planning. And this ended up reducing operating room time as well as anesthesia time. So that was a definite benefit. The cost, well, the cons, was one, the cost, because you had to buy the independent station, and the whole concept of diagnostic accuracy. 3D modeling really doesn't improve any of the diagnostic, your diagnostic accuracy, but it does give the physician a chance to have a better understanding of, in our case, the injury. I just wanted to show this because this is really pretty remarkable. 1987, this is a 3D model of a child who was going to have some surgery on the skull. But you could see that the detail was incredible. And I think people were pretty much awed by the work that Kathy could do back in 1987. And on this child, you see because it was a separate model, we could actually sort of remove the skin from the patient, get the skull. We can then move the skull around and dissect it apart. So then the surgeon, in this case it was a neurosurgeon, could have access to the problem within the skull. The next person I'd like to recognize is Mike Baumgartner. I don't know if you know him. Mike is a professor in orthopedics. He's the head of trauma surgery. But I knew Mike when he came as an assistant professor. And Mike taught me a very important lesson that's important for all of you, which has to do with organization. Mike would spend an inordinate amount of time with these complex cases, coming up with a surgical plan. And in fact, he would draw pathways on paper and tape them in the operating room. And of course, residents being residents, they laughed at him. They thought he was nuts, right? And in fact, it wasn't as bad as the Beautiful Mind story, but it was funny. And but he had good results. And I think it became very clear when Mike went away on vacation and someone from the community filled in on a complex case that, let us just say, did not work out so well. So I think that Mike's, compulsiveness of planning, preoperative planning, and not only planning, but in case of a problem or a failure, you know, an alternate pathway would be available. So here's going back. This is actually somebody with a acetabular fracture that we generated a 3D model. You could see we cut off half of the pelvis. You could see the femoral head coming through the acetabular wall. And, you know, in addition, there's a fracture of the iliac wing and an additional fracture. And these are the kinds of things that, in fact, Mike, you know, would sit for hours and plan and, you know, have an approach for the patient. I just also wanted to mention that Kathy also spent a lot of time. This is actually a 3D reconstruction of a prosthetic knee, and this is the tibial plate. So this is the metal portion of the plate, which is, let me tell you, is very difficult to generate. And in fact, here's someone with a abnormality, and we could actually calculate the angle of displacement on this loose prosthetic component. So the next thing that sort of came in the department was nuclear magnetic resonance. And believe it or not, this is a copy of a piece of an article from July 19, 1983 from the New Haven Register. And it discussed how Yale University, Yale New Haven Hospital, and General Electric were going to now build a breakthrough NMR scanner. And the person that probably was most responsible was John Gore. So this is a picture of John with the magnet that he actually brought over on a boat from Oxford. And it was transported and placed in the basement of the Heathkit Center. And this really was the beginning of the NMR story, not only here in Connecticut, but actually in the United States. You know, I've seen a lot of people come and go from this department, but I think one of the greatest losses that we had all over was John Gore. Not only was he brilliant, and I mean really brilliant, but he was funny. I mean, he belonged in the Monty Python group because of just his humor. But he was a great guy, and I miss him. Of course, he's now vice chancellor at Vanderbilt. They built a whole MRI center for him, and he's done very well. So here he is in 1983. He's building a coil that I'm not sure if it was for a head or for a knee. And in fact, here was his sidekick, Wade Holcomb, who, look at the size of the coil to the left, or to Wade's left, that they were building not only for clinical cases, but for research. So in 1988, 1989, the whole clinical MRI project was born here at Yale. And I think people need to realize that, you know, MRI was pretty much code for nuclear magnetic resonance. That's what we do, nuclear magnetic resonance. And it was the group on Madison Avenue in New York who thought that the public would not participate in this imaging because they thought that, you know, they were going to be exposed to radioactive nuclear material. So NMR became MRI. That was how the name came about. So this is a picture of the MRI Center, which is on Howard Avenue and York Street. This was the sign, and people were petrified. They see these signs, strong magnetic field. There's signs all over, and people just really would walk away from the original MR Center. And just to see, you can see that the physician's building is just being built in the back. You know, they're just laying down the construction for the YPB. So this puts everything into a little bit of a time frame. So for the radiologists, the residents, we started to learn a whole new lingo. We learned about proton NMR and about water molecules spinning around. And then, in fact, we learned that if we put in some kind of energy in the form of a radio frequency pulse, 90-degree pulse, we could flip these protons and then shut off. And then the MR scanner, back then, I thought of it as a big ear. It literally would hear the resonance, and through some mathematical computation, it would depict an image depending on muscle, fat, nerve, whatever is there. And then depending on the pulse sequences that were determined, we get different characteristics of tissue. So the 90-degree pulse that was needed to flip the water molecule was set to a defined radio frequency depending on the magnet strength. And therefore, the room needed to be shielded to prevent outside radio frequencies like WPLR or, the FM stations, AM stations from disturbing, the image acquisition. So here's an image that most people have never seen. This is actually Signa 1. This is the first MR room that had to be lined with copper. And the cost of the copper was around $250,000 just to line the room with copper. And it was quite an experience to walk in and see that. All I could think about was how much cookware I could use, but that wasn't going to happen. So we learned a whole new lingo about MRI. We learned about the advantages of MRI. We learned that there was no radiation, that we had multiplanar imaging, and especially for our group, the MSK group, we learned that there was increased contrast resolution. So the disadvantages, right, the main disadvantage back in those days was motion. So the body people were a little bit behind the 8 ball because, first of all, if they tried to do the abdomen, you had guts moving around. And if you had the chest, you had the heart and the ribs and breathing. So they were at a little bit of a disadvantage. So the two areas that began to emerge back in the late 80s were MSK and neuro. So here we go. The MSK group began because joints really don't move or breathe. Cortical bone gives no signal. So we had a window to the bone marrow, which was very, very different than CT. So CT, we could see the bone, but we really couldn't see the marrow. And therefore, we became, had a whole new field to look at shoulders and knees, hips and spine. So the next two people I'd like to call out were people who were very influential in terms of developing the MSK MRI program here. Peter Jokel, who ran the sports medicine conference, a clinic at Yale, and Kevin Lynch, who was probably the top arthroscopist, at least in New Haven, if not Connecticut. And I learned from both of them, especially Peter, the whole concept of the sort of the scientific method and asking questions. And without their help, I don't think that we really would have been able to advance MSK MRI here at Yale, or actually throughout the United States. I mean, Jerry Mink was in UCLA, and he was coming up with some of the early nomenclature, but it's like any other new type of imaging, you're really not sure what you're looking at. So we began a conference back in the late 80s at 7 o'clock in the morning, which was the MRI arthroscopy conference. So we would pick difficult MRIs, MSK MRIs, and give us our best guess. And then Peter and Kevin would actually show the intraoperative arthroscopy. So we would learn from either our success or our mistakes. And I have to tell you that 30 years later, we still have on Thursday morning our orthopedic sports medicine conference, where we go over MRIs for the exact same reason. So, I think that in terms of your profession, you always have to continue to review and, ask the question, what's the question? That's another one of the Katzisms. But anyway, it continues today. So 1990 comes around, and now we have a little trouble, not only with us, but with everybody, but there's a healthcare revolution going on. And we started having managed care, HMOs, the whole concept of DRGs, diagnosis-related groups. And in particular, in terms of the orthopedics, the accuracy of shoulder MRIs was coming into play. We weren't doing very well with it. And our friends in Japan at Olympus were coming up with a new technique called in-office arthroscopy. In-office arthroscopy. And this was a procedure that they would be able to, under local anesthesia, stick a needle or sort of a small scope into your shoulder, and they weren't be able to do surgical correction, but they would be able to do diagnostic arthroscopy in office. And not surprisingly, the price point was going to be at the same cost as the MRI. So if we have a diagnosis-related group where the orthopod was given a certain number of funds, X, and it was up to them to spend the money in any way they wanted, they were going to spend the money to themselves by picking a Olympus in-office arthroscopy unit. So at that point, I was faced with a dilemma, and gadolinium was sort of just coming onto the scene. We did all kinds of arthrography. We used contrast, we used an air or a combination of both, and to get better visualization. So we decided to embark on a program using gadolinium and do MRI arthrography. So in January of 1990, I actually presented the first cases in the United States. These were 44 patients at the Society of Skeletal Radiology in Marco Island, Florida. And actually, here's a slide from the original presentation with Peter Jokel and Kevin Lynch, but some also terrific orthopedic people who are still in the community, Jack Dagnall, Pat Rui, and Jack Kelly, who I owe a lot to, who worked very hard in helping us move this program along. Here's a couple of images from our original studies, which shows these are T1 weighted FATSAT images of the shoulder, and you can see that the contrast, the gatto, is quite bright. And on the image on your left, you can see the contrast on the first or second image is outside of the rotator cuff. That's the supraspinatus tendon and muscle. As well as on the coronal images, you can see that the tendon is torn and retracted. And in addition, you can see that there is a labral tear. So we started producing quite a bit of literature on our experience. And in fact, this is possibly one of the most quoted papers still in the literature, was by Pat Rui and Shirley McCarthy, looking at the effectiveness of MRI trying to replace diagnostic arthroscopy. Now, I can tell you that Pat tried to get this published in the orthopedic literature for well over a year, and it was not accepted. But we finally got it published in Radiology, and it showed very clearly that MR could replace diagnostic arthroscopy. Our next step in this adventure was looking at intravenous gadolinium. So at that time, gadolinium had only been approved by the FDA for neuroradiology, for intravenous use. But we actually were one of the first in the country to use gadolinium outside of the neuro access. We had to get, IRBs and all that stuff. And the patient was AP. He was an 18-year-old male who presented with femur pain. And you could see this is a radiograph of his distal femur. He's got a sclerotic lesion in his distal femur. And for those that are still remembering, this is called a Codman's triangle, right? Which gives you a kind of a suggestion that there's probably something coming out of the bone that's raising the periosteum of the femur. So here's an MRI, it's a T1 weighted image. You should know that the fat normally within the marrow should be bright. You can see that it's been replaced. And in fact, there is a huge soft tissue mass that was probably responsible for the Codman triangle. So we gave intravenous gadolinium, and to our amazement, this young man's whole leg lit up. Now, we knew that that was probably a problem, that, he may have had extension, but it certainly made it look much worse than it was. So there were some lessons learned from the experience. And one is that the bone tumors that we were dealing with are very vasogenic, so that the enhancement following intravenous gadolinium was actually exaggerated because of increasing blood flow, but not necessarily tumor extension. And because of this finding, this led to a change in the oncologic approach to osteosarcoma, so that the chemotherapy protocol was changed so that there was 3 rounds of chemotherapy given first, followed by a repeat MRI. And the follow-up MRI gave us a lot of clinical information because at that point, the vasogenic response was reduced and the true dimensions of the tumor could then be calculated so that a proper cancer operation could be performed. So the follow-up MRI showed not only that, but it also gave us a hint in terms of the effectiveness of the chemotherapy regimen so that we could detect necrosis of the tumor or in fact, no necrosis of the tumor so that in fact, if there was recurrence, the oncologist could essentially change the protocol around. So 1991, we embarked on our next adventure, which was percutaneous bone biopsies under CT. And this was better than normal, but still much different than what we do today. We were giving the patients Demerol and Vistarol IV. There was no conscious sedation at that time. We used a Yale-GE needle, which was pretty much a sophisticated corkscrew. We didn't have any kind of motorized equipment. But we did begin something here, which was radiology pathology correlation. And we were lucky enough to have some fantastic bone pathologists, Dr. Juan Rosai and Jose Costa. And basically a dictum was placed by them that no pathology was signed out until it was reviewed by a radiologist. So that, you know, a fracture, healing fracture could very much simulate an osteosarcoma. Now, the only problem at that time was that all of the imaging, everything was still done by film, and all the film was stored in Dr. Friedlaender's secret library. So, you know, when we were ready to try to biopsy somebody, our mission was always to try to find these x-rays, which we could never find. So one time, in fact, I tried to call Dr. Friedlaender. He wasn't here. I heard he was on vacation. Cell phones, believe it or not, were just coming into being. So I got in touch with him and I asked him where the films were. Well, this is what I got back. This is one of the first images. He's on Martha's Vineyard and he has no idea where the films are, but he's having a nice time with his family. So 1996 now. Now we have PACS. And the orthopedic group over in the YPB and our radiology group were actually one of the first people because we had a very small area. We could sort of control things. And so we were actually the first group in the Fuji PACS era to get the PACS rolling. Chest and all the rest of the groups were then added on slightly after that. But we had a very kind of controlled environment being over there in the YPB. The biggest problem for me is I never understood what PACS meant. And it took me a while to finally understand that it stood for Picture, Archive, and Communication System. So we recently had an upgrade and we have a new PACS system and things are working out much better, but it was a bit of a struggle with the Fuji system. So it's time to kind of bridge now to the future. I mean, we've been spending time in the 70s, the 80s, and the 90s, but it's time to come up to the 2000s. And, you know, the next person I'd like to recognize is Dr. Friedlaender, Gary Friedlaender, who was chairman of the Department of Orthopedics. Really an incredible guy, very just cultured and taught a lot about mentoring and how important it was to be able to mentor and to follow the rules. And I learned a lot from Gary. He's recently stepped down. But Gary also had a special part in his heart for radiology. We're very close. He, in terms of his orthopedic group, never really went anywhere unless Andy and I were with him to move to the next level. And Gary was very good at talking about the art of observation. That really was his big area. I think everybody can recognize the picture of Vincent van Gogh as a self-portrait. So I have a question for the crowd to say, does anybody know this painting? Does anybody know the name of this painting? Okay, good. So this painting is a portrait of Dr. Gachet. So Dr. Gachet was an internist who took care of Vincent van Gogh when he was in Arles. And interestingly enough, there are several other paintings of Dr. Gachet, But what I'd like you to do is to draw your attention to the vase, to the flower vase. And I'd like to know if anybody can tell me what that flower is. Foxglove, terrific. So that is foxglove, or another common name was digitalis. And Dr. Gachet thought that Vincent van Gogh was suffering from heart failure. So he would have him chew foxglove, in essence, to try to improve his cardiac output. But, you know, remember back in those days, we didn't have any testing to see if, in fact, how much foxglove Van Gogh was chewing. And in today, you know, we still deal with dig toxicity. So, you know, I started in medicine and I thought it was only fitting that I probably end in medicine. So you should have a little knowledge here. So when people are dig toxic, they come in with headache and confusion. They can have delirium and they have marked visual disturbance. They see swirling or blurred vision and they see all kinds of shades of blue, yellow, and green. So this is The Starry Night by Vincent van Gogh. So I'd just like to pose to the group and to everybody who's listening on the internet, you know, do you really think he was crazy? Or could he simply have been dig toxic? So I think it would be remiss for me to kind of end without giving special recognition to a good friend. You know, I loved Andy's intro, but he's more than that. He's been with me since residency, went away to Philly to do a fellowship, and he's been a loyal friend and a great teacher to me. He always kept me in line, make sure I got all my Yale requirements done. He did yell at me when I didn't, you know, QQ agenda, but you know, he's a great person, and I'm very happy to have passed the torch to him. I have seen him with the residents, you know, and sometimes he's a little tough. The residents say, you know, he could be pretty tough. And if he asks for a differential and they give him some cockamamie answer, he would say, well, God, that's about, you know, as possible as me riding a unicorn. And I never could really understand where that actually came from until I came to this picture. So I think I have a little bit better understanding now. Okay, so in conclusion, you know, these are the things that I'd like you to walk away with, that as we say in the tea world, sip happens. And so every once in a while, you know, we need to be reminded of our history, because great things have actually happened here at this university. And I think sometimes we lose sight because of all of the mishigas that goes on here and, you know, changes that occur. But let me say, we've had some really important people and some important advances that have taken place at Yale. And so my feeling is that the future is quite bright for Yale Orthopedics and Radiology. But what I really want the people in the audience, especially the residents and even some of the young faculty who haven't been here that long, to really walk away with the Yale lessons. And those were the ones that were taught to me by Dr. Thier, who taught me about leadership and commitment, by Dr. Greenspan, who talked to me about the commitment to family, by Dr. Baumgartner, who really explained to me about organization, by Drs. Jokel and Lynch, who talked to me about science and creativity, and finally, by Dr. Friedlaender, who talked to me about mentorship and loyalty. So after 42 years, 3 fields of study, 7 Yale presidents, 5 medical school deans, 3 Yale CEOs, 8 radiology chairmen, 2 orthopedic section heads, 2 orthopedic chairmen, faculty, hundreds of residents, 70 fellows, technologists, who I'm very happy to be here today, secretaries, assistants, aides, security. It's time for me to move on. So at the end of every academic year, I've used these words to say goodbye, to give my very best wishes to the future of our profession. Happy trails until we meet again. Thank you very much.